Hi, everyone. Good evening. And I know that it is quite late for all of you. And my colleagues here are here to present nightmare sessions. And I was joking with them that we are waiting till night so that they can present the nightmare sessions. I don't want to take much of the time because all of you guys, I think a lot of you have come for the nightmare session. I think my topic is slightly more pertinent to people who are budding electrophysiologists or electrophysiologists. I'll make it the other way around. I'll tell you, what I think about when I do a procedure, and I'll leave it at that. So when I do something, I always think, is it useful and is it necessary? And I think that's the question which you need to ask whether you're doing intervention or EP. So always you need to have a very clear answer. The first thing with my talk with ICD, is it useful? There is plenty of papers telling it is useful, and more time from the device implantation, the more lives are saved. It's very simple. So it is useful. Is it necessary? And I think in medical practice, we get bad names because this is where you go wrong. Device is implanted when not indicated. This is Washington Post in 2015. And why does that happen? Because the experts don't do it. Everybody does it. Why do we do it? Is it because we have lucrative? Is it medical legal worry? Some people thinking that if I don't put it, whether somebody will put a case against me, or do we miss the holistic approach? I think it's a combination of a lot of these things. And I always tell to people, implantable cardioverter defibrillator saves lives, but if they are not managed correctly, they can make it harder to have a peaceful death. And that's same with all your intervention. Okay, you always make sure that you don't give them a painful death. Any procedure, be clear about your indications. Think about alternatives to your proposed procedures. Approach. I'm not going to go into the approach for any intervention. Have you considered asking experts? If you're doing difficult job like an ICD, which is a lifelong devices and other things, think, is it useful for your patient? Have you explained and counseled the patient's parents? Do they understand implications, and will it affect their quality of life? Are you going to make them better, same, or worse? You need to be very clear. So I'm just going to skip some of these slides. I think with ICD, I would say class 1 indications, you're justified. Class 2 indications, think again. Have you asked your colleagues, or have you asked the experts? Because the numbers are small in pediatrics. So unless you have done a lot, you shouldn't do it unless you are an expert yourself. I'm not going to go through this. All of you read. Heart failure, again, the data are missing. There are some primary indications. And especially if you have a heart failure, just unlike adults, always think, is there, although I know the number is small in children who benefit from conduction system pacing, but think about it. I've seen people missing it and putting an ICD. And if you're putting an ICD, if your lead is not in the right position, then you're causing bundle branch block, left bundle branch block, and then you're not going to do them any good. So you need to be 100% sure where your lead is going to be, even if you're going to put an ICD. Structural heart disease, I think it's very difficult to sort of cover this topic. A lot of things go through my mind. If you have a VTVF, I would do multiple additional investigations, including MRI. I would think if there is any treatable cause like hemodynamic consequence before considering ablation, unless it's absolutely necessary, or then consider ICD. Yeah, I've said that all of you have to read. I don't have to tell you a lot regarding indications. Then the question comes, whatever indication you do, which one? So, I've done practice in a lot of different institutions. I've seen people doing it differently. There is at least 4 ways of putting ICDs in small children. And which one do they select? Depending on the surgeon, whatever he is happy, because you need the surgeon to give you the access to put that coil. So there is no right or wrong answers. So I've just taken some of this slide. This is my teacher, Dr. Jantel, who is in Brompton. And so the only thing concentrate is look at the amount of material there. These are children who are 9 kilogram, 10 kilogram. Look at the amount of material in them. Okay. Again, look at this. So this is through the transverse sinus of people putting, or in the pericardium. This was in the transverse sinus. This is my friend Vinay. I asked him for some of these, and the subcut. And this is the last one which I saw when I went to UK this time around. They put SVC coil, big one from the front, one from the back, and then you have a pacemaker here. these are all under the skin, just beneath the fascia. And what I felt was all of these have a lot of foreign bodies in a small child. High risk of infection, inflammation, pain is an issue, skin erosion, and redo is a challenge even in the best hands. And your child will be like that, and I'll promise you, you will be like that as well, because the parents are not going to leave you. And the questions to answer, I have to say it is a bit less in India, but these are the questions they will ask you. What is an ICD? What is arrhythmia? What will it look and feel like? What does the shock feel like? When it could shock me? Can I play sports? So plenty. And can you answer all these questions? And the last ones are cosmetics. Don't think about the cosmetic as a light issue. For a teenager, it is very important how he looks like. So anything which you put doesn't look very nice. And then the last question some people have asked me when I'm abroad, will I die? And this will be your face by the time they ask you the questions. And then that doesn't finish there, because you have parents. So then the parents have their set of questions, because they're quite high on emotions and anxiety. And the last thing is they still have to learn CPR and basic first aid. And believe me, you will be like this. You'll be needing a cup of coffee answering all these questions, probably multiple cup of coffee. So for me, ICD, if you're going to put one, you need to really, really, really think whether you need one, especially in children. Okay. And there is, yeah, sorry, I've just put that, you're not finished yet. So you put an ICD, you think you've done something, recurrent shock. What is your support system? Whom should they call? Do we have that in India? We don't. So that's a difficult thing. Appropriate shocks, good, you have helped the child, but they'll still not like you because the shock is not nice. They will be emotionally disturbed. Parent and the child will be disturbed. So it is extremely difficult. Inappropriate shocks, they will really hate you. And that is a significant number in pediatrics because, a lot of them, the sensing is not directly on the ventricle, which I've shown you, and then they have more inappropriate shocks. So it is extremely difficult. So I'll just conclude here, say that think before you put one. Have you got the indication right? This is for you for all the procedures, not only for ICD. Have you documented it? Have you spoken to experts, and have you documented that you have spoken to experts? These are the things which is going to help you, because medical legal cases are becoming more and more in India. Document, document, document. I think all my fellows know that. I keep telling, your documentation has to be absolute if you're doing one. Approach, as I've said, it largely depends on the age of the child, what's available in your country, and you need to discuss with your surgeons, especially in smaller children. And this is a case scenario. I'll just put to you that how difficult it is. 18-month-old child. This is a child whom I saw when I went to UK this time. Admitted for PDA ligation. It was a late diagnosis. Had VF in theta. And then they come and show me the ECG. Very prolonged QT, 600 millisecond, had bradycardia. And then when I go through the history, the child has a syndactyly. When I carefully look at the ECG pre, it is around 480 milliseconds. So it's quite easy to miss for a pediatric cardiologist. It's not a frank long QT. So it was the first question with syndactyly, PDA, it comes to your mind is Timothy syndrome, which is calcium mediated, and they have extreme bradycardia. And Timothy syndrome, believe me, is very, very rare. You might see as an electrophysiologist once in your lifetime, or probably two. When I asked my teacher, she said she has seen two, and she's very experienced and she has a very big caseload. So what did I do? So to buy time, I put a temporary pacing. We sent the genetics and spoke to the family a lot of time, because in UK, I do have a lot of time, which is difficult if you're here. And then I told the parents the options. What would I have done? I said that because there is extreme brady, I cannot give beta blocker unless I put a pacemaker. I said that's the easier way of getting out. But can I save your child 100%? I don't know. You have to document all of these things. I said, still you can have VTVF. And then they said to me, they were actually okay with it, I have to say. Then I spoke to 4 colleagues from UK, including my teacher. And then I asked an expert on Timothy syndrome. There is an expert. He has 10 cases or 12 cases of Timothy syndrome. So they said maybe ICD is safer. So we decided on the ICD. And the last one, which I showed you, which we put one from the back and the front, that is the one which we decided, because that's the most preferred one now. because the surgeon doesn't have to open the pericardium so it's much easier for them. So it took 2 weeks to heal, a lot of pain. And then there is a brief moment of happy time. They go home. They come back after 3 weeks post-discharge, swelling, fever, infection. You have to remove it en masse. Then I spoke to the expert again. He said to me, this is quite interesting. Pacemaker is quite sufficient. Actually, 3 of my patients have pacemaker only. And in Mayo Clinic, they put pacemaker as the first indication. So, even the experts. So that's the reason if you're doing a difficult case, always ask. Even the experts get it wrong, and for us, it is very easy to get it wrong. So it all leaves you confused at the end of the day. And I always confuse people. I think that's interesting. But because that's life, I think all who've done enough, that you always do mistakes and you learn from it. Thank you all.
Thank you, sir, for this interesting talk.
An interesting talk. In fact, this is absolutely true. Long QT syndrome, so we have a very high case load. So far, we have not identified a case suitable exclusively for an ICD. We do with the beta blockers and cardiac simulated innovation. If you see the guidelines, at least a couple of guidelines in the past missed pacing as a therapy at all. And now it has come in the guidelines recently, the last guidelines. Pacing has been traditionally used in good number of cases. I mean, for the last 20 years, we have been doing pacing in long QT, isolated cases, not in all, but who is refractory, otherwise QT is still prolonged with the TDP and all. We put atrial rate at high, and it works very well, actually.
Yeah,
and cardiac sympathetic innovation also adds to it.
Absolutely. I would sort of, and that's the reason I say you have to practice according to what is available in your country. You do a certain cardiac death clinic, or you're putting an ICD abroad, as Jonathan Skinner showed. You have pediatric cardiologist, you have your fellow, you have geneticist, you have 2 arrhythmia nurses. So, it's a very, very big team. They can do that and they can follow these patients up. For us, we have to modify it. And I found it easier to do the same way. For me, I gave beta blocker. And if I think it is causing significant brady, I put a pacemaker. And if there was any worries that they will have, I would consider the left cardiac sympathetic denervation and then think about.
Short comment again. One patient who was referred, planned for ICD from 2 different centers, major centers, not blaming them, had multiple episodes of TOD states, even on beta blockers, came 10 years back to us. This patient we put on mexilative and later on proven to be long QT3. Not a single event in the last 10 years, and patient is now a nurse actually. So single genotyping based therapy, ICD was avoided. Beta blocker plus mexilative.
Thank you.